It is really a great pleasure to invite to the stage Professor James Shapiro from the University of Alberta in Canada. Please come up, I will introduce you whilst walking. So James led the team that developed and tested something that is globally known as the Edmonton Protocol. And this protocol really revolutionized the treatment for type 1 diabetes. As for the first time, a series of patients were able to completely stop their life-sustaining insulin injections. Welcome.
Professor Hillner, Wilmot, Mason, Ian, Johan, Chris, thank you very much indeed for this wonderful privilege to be here amongst you all and for putting together a really quite spectacular symposium. I think we're all very grateful and grateful to the Royal Society. Ladies and gentlemen, family and friends. The title of my talk is Cellular Transplantation of Human Islets or Stem Cell Progenitors in the Treatment of Diabetes. These are my disclosures. So thinking about this journey over the last 350 years, since Robert Hooke, I will point out along the way, 230 years along that journey, the very first attempt at a cellular transplant occurred in Bristol here, at the Bristol Royal Infirmary, where Watson Williams and his colleague Harsant placed small pieces of sheep's pancreas into a 13-year-old boy who was dying from the ravages of diabetes. The transplant, of course, was a xenograft. There was no anti-rejection medication. The urine glucose did fall for a few days before the boy rejected the graft promptly and then died. So now we're 350 years later, and we've come a long way. Here's a patient wearing a continuous glucose monitor, you can see here on the belt, and monitoring the blood glucose hour by hour, day by day. Despite this kind of technology, which has been a big advance, I think, for many patients with type 1 diabetes, this patient was found dead in bed at 9 o'clock in the morning from a fatal hypoglycemic event, perfectly recorded on this kind of technology. This technology is improving. For example, Steve Russell and colleagues have published the combination of a bionic pump that delivers both insulin and glucagon to provide both the regulatory and counter-regulatory hormonal control for optimizing diabetes control with some improvement. And here, for example, you can see the continuous glucose monitoring curves for the patients wearing these kind of devices that can be achieved today. And despite the fact that patients are not facing severe hypoglycemia, this is still not a normal response. You can see there's still quite marked and varied fluctuation in glycemic control, even with this kind of technology in its optimized form. So there is a place for cellular therapy. It's basically regarded today as being on the fourth line here. You can see the first line is educating patients. The second line is considering continuous glucose meters and insulin pumps. The third is to consider the use of advanced technologies, including low glucose suspend on those pumps. And then finally, when these treatments fail, patients can be considered for either islet cell transplantation or potentially whole pancreas transplantation. There's been a lot of interest in cellular therapies in diabetes. Google, for example, has just recently invested a large amount of money to try to drive the treatment and cure of diabetes forward. And so here's a patient who received a single donor islet transplant. This one actually happens to be from Camilla Ricordi's group in Miami, but we have several patients just like this, wearing a continuous glucose meter. These patients with really severe glycemic excursions, they received a single donor islet infusion, 11,000 islet equivalents per kilogram, and then maintained a perfect glycemic control and are insulin-free since, with a hemoglobin A1C of 5.5%. This can be readily achieved, I won't say in all patients, but in most patients, at least for a period of time, as later I'll show you, provided a transplant procedure is carried out and the patient remains on lifelong immunosuppressive therapy. So these are the patients we consider today for an Islet Alone transplant. They have to have type 1 diabetes of more than 5-year duration. They have to fail on standard insulin and intensive insulin therapies. And we have various scoring systems that I won't go into that really classify patients as falling into these groups failing on standard therapy. And we estimate today that there are around 5 to 10% of the population of patients with type 1 diabetes that will fulfill these very stringent criteria. And again, immunosuppression is needed, and there are potential risks from the cell infusion. And if we didn't have to face these two risks, then potentially we could widen that gap and treat most, if not all, patients with type 1 diabetes, including children, which at this point we've not been prepared to do. So back in 2000, we carried out the Edmonton Protocol. We've continued to follow these patients and expanded our experience ever since. I can report today that 4 of our first 12 patients still remain insulin-free, 2 of them with their original grafts back in 2000. And the longest patient insulin-free now is 16.5 years after his islet transplant in the year 2000. And he received 753,000 islets, or 13,000 per kilogram. We recently celebrated our 500th islet transplant in Edmonton back in April. We've been very pleased with the ability for the hospital systems to accommodate this into standard practice. And you'll see, though, that most patients, although we've done 516 patients as of today, most patients receive more than 1 islet infusion. So on the average, most patients require 2 islet infusions to provide sufficient mass to come off insulin for a period of time. We've continued to collaborate internationally with many different centres, and there are around 37 active sites in islet transplantation presently, and around 1,700 patients treated across the world with this kind of therapy. But I will admit that in the last few years, the activity has dampened, mainly due to the fact that this is an expensive therapy, and research grants on their own really cannot continue to support it. So activity in the US has been limited to activities as part of a clinical islet consortium. So the automated method for preparing islets was developed by Professor Camillo Ricordi, who works in Miami. He developed the Ricordi chamber, and that's really the technique that is still used today for high-yield, high-mass isolation of human islets. And here is a human pancreas being distended with the collagenase enzyme, and here's Doug shaking the chamber in the middle of the night, and that's still his hands-on experience and Dr. Tatsuya Kin's experience with over 1,800 islet isolations in this way has provided really quite phenomenal advances. And we can see that when we started this in 2000, our average ability to transplant a prep was only around 20 to 25%. And now we can transplant a prep 60 to 80% of the time. And the islet yield that we get from a single pancreas used to be around 200,000 islets, and our mean now is around 400,000 islets. So there's been terrific progress in the ability to isolate high-quality islets over the course of time. We still continue to use this, which is the icebox, for moving pancreas organs around the country. In fact, all organs for transplant are moved around with the icebox technology. And this is changing, however. We're currently experimenting with this approach, which is called a Persufflator, which is developed by Clarkus Pappas and colleagues and company Gainer. And with this technology, we're trying to blow humidified oxygen into the pancreas while it's being transported. And we can put these on their own separate seat on Air Canada and ship the pancreas organ across the country to try and improve the viability of islets. And the early data suggests that this is indeed promising, and I won't go through all the data here, but very good continuous perifusion data indicating that the islets release good insulin. We're also moving forward with a trial in collaboration with Professor Peter Friend in Oxford, who's designed a similar, very high-tech machine for moving livers around the country, and we were able to keep a liver. In fact, we did a liver transplant last week. We were able to keep the liver transplant on this device for 22.5 hours while we slept overnight and did other surgeries. So now these kind of technologies are moving forward in heart transplantation, in lung transplantation, the liver and the pancreas, as I mentioned. And I think this will really be a game changer and allow us to use many more organs for transplant in much better quality than we ever did before. And here's, for example, is one group with Mike Nicholson's group in Leicester, where they've tested out this technology in a discarded human pancreas. So the way we implant islets today is in the liver by a simple non-surgical technique in the radiology department with interventional approaches. It's really built on the work of Paul Lacey. He was the first to reverse diabetes successfully in rats in 1972 with Ballinger. And they subsequently reported a year later that the portal vein implants were very successful in reversing diabetes, but when the islets were placed naked in the peritoneal cavity or under the skin, they didn't work. And it's really from this work that the portal route for delivery of islets was developed. So here's a patient undergoing a transplant. The patient's awake. We can talk to them throughout it. They have some local anesthetic. We can look on the fluoro screen. We can place the catheter directly in the portal vein with the help of the radiologist. We can simply infuse the cells, drip them in under gravity. You can see some of the cells going through there in the tubing, and I'm just going to skip to the end of this, where the most important part is what we do next, which is to plug the tract here. We use avitine paste, which is microfibrillary collagen, and by giving the patients full dose heparin and injecting this paste down the tract, we can prevent any risk of bleeding. And it really has made this the safest transplant that I've been involved in, of any kind of transplant. So you can see the paste is delivered into the liver, and we can see that because we mix it with contrast. So this is a very safe transplant. If you look at the overall patient survival, over 16 years of experience from Edmonton, we've got 96% patient survival. And the deaths that we have encountered have all related to pre-existing diabetes, mainly from myocardial infarcts in patients with underlying coronary artery disease, hypoglycemia. We had one suicide in a patient who had good islet function for a while, then rejected. And then we had one patient get Creutzfeldt-Jakob disease, probably unrelated to the transplant or to the immunosuppression in that particular case. So to our knowledge, to date, there have been no deaths as a direct relationship to the transplant or to the immunosuppressive medications that have been used. We have experienced adverse outcomes, as you'd expect, when we use tacrolimus, which is a potent nephrotoxic but powerful anti-rejection drug. We have seen end-stage renal failure occur in 1.3% of patients. We have had opportunistic infections occur rarely that can be treated by discontinuing the medications. We had one patient develop a post-transplant liver-proliferative disorder, which has been treated medically and surgically. And we've had 6 treatable skin cancers to date. What about outcomes? If we look at the original Edmonton Protocol series, we demonstrated after the first 5 years that we saw a marked fall-off in rates of complete insulin independence over the course of time, such that by 16 years afterwards, only 22% of patients remained completely free. That includes a few patients receiving late retransplants. What we did, however, note was that 37% of patients continued to have good graft function with less than 10 units of insulin per day, and 70% of patients, just under 69%, continued to make C-peptide and continued to have a hemoglobin A1C less than 7% and were protected from hypoglycemia, so therefore continued to gain considerable benefit from this kind of intervention. However, we focused both locally and internationally in trying to plug the holes in the bucket to try to see if we can get more of the cells surviving early and late, preventing acute and chronic rejection and trying to minimize the early injury to cells. And I'll briefly mention some of the work that's occurred and progress in this area. For example, we've been collaborating recently with Professor Yuval Dor in Jerusalem, who's been looking at the DNA methylation patterns in peripheral blood after patients receiving our islet transplants. And you can see there are quite high peaks in the first hour or so after the transplant, still suggesting that a large proportion of the cells that we inject in the liver fail to engraft and survive. And the function that we see in the patients is really a reflection of the small numbers of cells that eventually engraft. We know that autoimmunity can recur after an islet transplant. Biopsies have shown that. And so working on this circle of inflammation, immune activation, and tolerance, trying to promote islet engraftment and minimize the need for chronic long-term immunosuppression remains a major focus of several groups involved with islet transplantation. So for example, now there are at least 6 centers that are reporting 5-year outcomes with insulin independence rates greater than 50%. Including our own. And this kind of data is very compelling because it's the same kind of response we would expect with a whole pancreas transplant. So what we can achieve now in 2015 is the same kind of outcome with a cellular transplant treatment as we can with a whole pancreas transplant, admittedly in highly selected centers. We focused on the use of an antibody, anti-CD52 antibody, Alemtuzumab, we've used in over 100 patients. This really began with a collaboration with Professor Sir Roy Khan in Cambridge, and we used 3 different protocols with this over the course of time, and our current protocol involves use of very standard maintenance immunosuppression with tacrolimus, Celcept, and 2 anti-inflammatory medications, anakinra and etanercept. So this shows the C-peptide function of our patients over time. 92% of patients out to these in years post-transplant, at 5 years post-transplant, continue to have C-peptide function in the Alemtuzumab treated group compared to the 16% in the original Edmonton Protocol series. And then we've recently added, as I mentioned, first in mice and then in patients, the combination of these anti-inflammatory medications, anakinra and etanercept, which significantly improved marginal engraftment of human islets in mice. And these are the C-peptide effects with and without the anakinra etanercept. And when we look at the insulin independence rates here shown at 7 years in our current protocols, you can see that 58% of patients remain insulin-free at 7 years with the Alemtuzumab approach, compared to 11% in the original Edmonton Protocol patients, excluding those that got retransplanted. And these are the kind of metabolic responses we routinely see. The line there is hemoglobin A1C of 6.1%. You can see before transplant the levels are very high, and this is normal. So most patients achieve a normal or near normal hemoglobin A1C after a transplant. And similarly, when we look at the scores for protection against hypoglycemia, very high Clark score before transplant, maintained at normal or near normal. Same thing with the hypo score, same thing with the lability index over the course of time. So for patients that have severe brittle hypoglycemic risk before transplant, the transplant themselves makes a huge difference to the patients. We've collaborated with Professor Bart Rope in Leiden in the Netherlands, looking at the Alemtuzumab tacrolimus cell-sept immunosuppressive approach. And what he finds is that in our patients' serum samples we send him, he sees very marked IL-10 deviation and with the Alemtuzumab tacrolimus cell-sept approach, and very marked suppression of autoantibody responses, suggesting that we might be more effective in controlling both auto and alloimmunity with the Alemtuzumab type approach. What about the impact of islet transplantation on secondary complications? Garth Warnock in Vancouver has run a randomized crossover trial comparing patients with best medical therapy with islet cell transplant, and in his series has demonstrated reduced progression of eye disease, retinopathy, and less decline in renal function by glomerular filtration in the islet transplanted group, despite the use of the anti-rejection drug tacrolimus. So this has been encouraging. We've been working closely with the NIH consortium of clinical islet transplant trials. We've run 2 trials in the US, CIT-06 and CIT-07. One is an islet after kidney transplant trial, and one is an Islet Alone trial. And these are both essentially registration trials designed with the FDA involved to get a biological license application secured for islet transplantation. So the data from this trial is now complete. CIT-07 has been submitted. The FDA have looked at it and have been very encouraging about the possibility now of awarding a biological license for islets. I showed you that most of our patients require 2 islet infusions in Edmonton to secure insulin independence. Some centers have been able to achieve single donor islet engraftment success. Sometimes this has been through very careful donor and recipient selection. Obviously, if you pick a small recipient that needs very small amounts of insulin to start with, you can easily make that a patient that's a single donor with a single infusion. So this still remains very much a challenge for us. So we've carried out research studies and then clinical studies. First with apoptosis inhibitors, we've tested ZVET-FMK, EP1013, which is now F573, and another pan-caspase inhibitor called IDN6556. And what we essentially found in all experimental studies when we tested this in mice, in human islets in mice, and in large animal studies, that these kind of agents were able to reduce the minimal islet mass needed to reverse diabetes by around 80%. And so we've been able to take these kind of studies forward now to a clinical trial with the support of the Juvenile Diabetes Research Foundation. We've completed the first phase of this trial. We're in the dose escalation phase currently. But the challenge we've had is with this agent, since IDN6556, which has not been used in patients before routinely, we don't have the kind of safety data to allow us to escalate the dosing to what we found to be very effective in animal models. So I think that might be a limitation and perhaps a common theme of research as well as we move promising therapies from mice to men. So finally, I'll just recognize that islet transplantation only addresses a very narrow spectrum of patients with brittle hypoglycemia. And if we're really to have any impact at all in the entire spectrum of diabetes, we clearly need a different kind of approach if we're to address patients with type 2 diabetes, patients with new onset diabetes. So I think the islet transplant therapy really is just a very small starting point here. So we've been working on alternative retrievable sites for islet infusion. We've been carried out a clinical study with Cernova Corporation in London, Ontario. They have developed a device like this. It's like the size and shape of a tea bag. It's placed under the skin. It remains there for about a month or two. And then during that time, new vessels form around the device, and then we can go back in at a delayed time point and remove the rods from the device and then infuse islet cells into that. And this has been a promising approach, at least in small animal models, when we tested it, recently published on this, demonstrating that marginal mass islets engraft quite effectively in this device, with some delay in reversal of diabetes compared to the kidney capsule or intraportal approaches. So what we've got data on to date is 3 patients that have evidence of surviving islets over the course of time over transplant, and evidence of new blood vessel formation with von Willebrand staining. But what we have not seen to date is detectable C-peptide in these patients or robust islet function, despite the injection of large numbers of islets into the devices. So it remains to be seen how effective these will be. We've also been working locally on what we've called the deviceless approach, and Andrew Pepper and Rena and the lab team have been very much involved in taking this exciting approach forward. And all we've done here is placed a radiological 5 French Cook catheter under the skin of a mouse, and we've carried out this obviously many hundreds of times, and we found that we can induce neovascularization in a very controlled way, and then we can remove the plug at about a month, and then put islets or stem cells in that place, and again find a very effective neovascularization. This is the backside of the skin. You can see the new blood vessels have formed, and these are the mouse islets or human islets that engraft very effectively into this space. And again, we can reverse diabetes in a very robust manner, but with some delay to normal glycemia compared to the kidney capsule site. And here, for example, is implantation of ViaCyte CYT49 cells that are making good levels of human C-peptide over the course of time in these deviceless mouse models. These are ongoing studies. In the clinic, we've also been looking towards other sites for injecting islets and potentially stem cells in the future. We've looked initially at the gastric submucosal site. This is a collaboration with the University of Pittsburgh with Professor Cooper and colleagues there. This is a very simple approach that can be carried out as an outpatient procedure. They tested and really validated this approach in the large animal pig model. And here we've been able to test this out in patients. This is myself with Dr. Gopal Sander, where we're simply injecting islets with a gastroscope with a patient awake but sedated. Patient goes home a couple of hours later. We can inject the cells directly under the lining of the stomach here. I could try to skip along here for time. So here you can see the needle goes in, we make a bleb, and then we inject the islet cells, and in theory you could put stem cells in exactly the same site as that, and you can go back over time and potentially biopsy these sites. So we've done a couple of patients with this approach to date, and I can't really comment on how successful it will be in these patients. It's too early to say, but we haven't seen we've seen detectable C-peptide function, but we haven't seen any insulin independence in this approach so far. So if we look at all the human data with placing islets, the only place that islets have worked to date has been, and provided insulin independence, has been in the portal vein. And that was true up until just a couple of weeks ago. The omentum has been explored as a potential alternative site for islet implantation, really originating from the work of Dr. Scowthorne from Newcastle and John Ferguson, where in the anatomy labs they placed islets experimentally back in the 70s without immunosuppression, and did show some early engraftment. Camillo Ricordi in Miami has recently moved forward with this approach, placing islets on the surface of the omentum with applying some tissue thrombin on top of them. And the first patient that they treated with this approach has been completely insulin-free at an early time point after the infusion. So this is very, very encouraging data so far. And these again are the continuous glucose monitoring curves with excellent glycemic profiles after transplantation. We recognize that the anti-rejection drugs that we use for transplant can still remain a challenge. Here you can see these are human islets on a perifusion, either in the absence or presence of tacrolimus. And when we put tacrolimus in the mix at the standard concentration as we would use clinically, we see a flat line. So the islets basically stop making insulin during the time they're exposed to high-dose tacrolimus. We can reverse that now with an experimental drug, anti-aging glycopeptide, and we've got ongoing work in that area. But just really to point out that the anti-rejection drugs we use, tacrolimus, Celcept, rapamycin, could really not only provide a challenge to neovascularization and survival of human islets, but they still may provide a challenge to us if we need to use these kind of drugs with stem cells, because we don't know how well they will differentiate and function in the presence of these drugs. So finally, moving on to briefly about the progress in stem cells for islets. Many of you will be familiar with the work of Dr. Doug Melton, who has been able to generate more advanced stage 6, stage 7 cells from original human embryonic stem cells. And these cells seem to have very similar function, perhaps not identical to human islets. And similarly, the work of Tim Kiefer in Vancouver has also reported in September last year in Nature Biotechnology a similar approach that provides mature stage 7 beta cells that have similar electrophysiological responses to human islets. Again, these are maybe not perfectly functioning human islets, but they offer the possibility of being very mature type cells for safe transplantation. We've been collaborating with Cythera and then Novacell and now ViaCyte for over 12 years now with their pancreatic endodermal-derived CYT49 cell line, and we've been very pleased to see that progress from the earliest experiences now to a clinical trial which we're actively involved in Edmonton. The preclinical data in mice has very clearly shown no hypoglycemia, that the cells can be enriched to minimize the risk of teratoma, and that these cells seem to be very stable. And the clinical trials are moving forward now by co-transplanting these PECO1 cells, they're called, or CYT49 cells, inside an immunoisolating membrane in a device that mirrors, is not identical, but mirrors the Theracyte device. And these can be placed subcutaneously. So this trial is approved by the FDA and by Health Canada. It began back in San Diego in October last year, and we've just recently completed our second patient with this approach in Edmonton, placing the cells under the skin. And these are first-in-human trials. They're not designed to be therapeutic, but they are designed to allow us to take out sentinel devices at different time points so that we can see how much function there is. So very finally then, just to mention that along with these approaches, there's a lot of work occurring in immunological reset and trying to regenerate injured islets at the time of diagnosis of type 1 diabetes with stem cell transplantation and immune modulation. I think this is also a very exciting and promising approach. We've been very fortunate to be funded to carry out a clinical trial with a drug called plerixafor, which mobilizes CD34 cells into the periphery. And by combining the drugs that we found to be effective in the Edmonton Protocol without tacrolimus and without CellCept, so the anti-inflammatories and a single dose of alemtuzumab, we're anticipating that this may, together with GLP-1 analogs, provide an opportunity to reduce inflammation and maybe promote regeneration at the time of diagnosis. So these are clinical trials now in development. So this is where we're at, I see, in diabetes. We have islet transplantation. We have the really great promise and now robust entry into clinical trials with stem cell transplantation, and the possibility, too, of regenerative medicine directly and locally within the pancreas as part of this nexus of intensive research occurring and progress that clearly has occurred in type 1 diabetes. It's very exciting times. So just to sum up, we've really made progress with islet transplantation, 58% insulin independence rates and 92% C-peptide positive rates now at 7 years after current islet transplant protocols. Alternative retrievable sites are in clinical testing and development. There really are inroads occurring with the ViaCyte and with other stem cell-derived technologies and cells in patients, and the regeneration trials are making some progress. I think there's no question that cellular transplantation will become the mainstream treatment of patients for type 1 and type 2 diabetes over the course of time, and clearly the indications will broaden as these therapies demonstrate benefit and are shown to be safe. So on behalf of a terrific team that I have the fortune to work alongside in Edmonton and internationally, thank you very much for your attention.